gallop through history really. I mean, John's a really hard act to follow, but I'll do my best. But you will see incredible overlap really, and you will see that we're actually talking about the same dynamics, the same threads, you know, the same kind of rottenness, I suppose, really. Our history in the Republic is a little bit different, because for a start we never really had an NHS. The medical profession, actually, I don't know if there's any representatives of the profession here this evening, but they actually nobbled that before it could even get going. And when you look back, you know, you realise that we had the Royal College of Surgeons, for example, which actually started out as a bunch of barbers in Dublin, but of course they're well beyond that now. And but they actually had their roots in a charter from, I think it was George III. So like 500 years before the state was founded. So you can imagine that the whole power balance there, you know, from, you know, day one was just totally out of sync. And the state really has never caught up, you know, even to this day. But we started to trade in health in 1953. There was a very famous mother and child scheme. Some of you might have heard of it. Nobody could understand what it was all about, but what it was really about was it was our first attempt at socialised medicine. But the medical profession weren't having any of it. They nipped off to the Catholic Church, and the combination of both was completely unbeatable. And the mother and child eventually was passed in this really emasculated form. Interestingly enough, it was based not on female midwives but on GPs. So there was a whole medical monopoly built in there from the very start, and they also had really mean you know, postnatal care for women, all of that. Everything was just like cut right back, pared right back, and even to today, we have some of the worst postnatal care in Europe, like really the worst. In fact, mothers now are turfed out of hospital. Well, you know, if you're having a first child, you can get a stay for like 48 hours, and the second child, well, home 24 hours, no support in the community, no, nothing, nada. So, you know, there is a real legacy there in history. So 1953, what happened? We gifted our beds in our public hospitals to medical consultants for their private practice. So we had beds that were private, semi-private and public. Fast forward to 1970, public hospitals were allowed to actually charge for their services. So we were now beginning to trade very seriously in health. And I was actually at a conference, yet another one of those conferences today, something grandly called Health Summit, Sunday Business Post, which is, you know, a business paper. It's not a bad paper actually, but it's obviously it's totally pro-business. And I found out that there's been, as you know, I mean, we had our referendum on the Lisbon Treaty today, which some people are watching with bated breath. But it was interesting today. Somebody from A&L, Goodbody, one of our leading lawyer firms here in the South, actually told us that competition law applied, that competition law had applied to healthcare since 1973, when we joined what was then the Common Market, and that, of course, we've had our own competition law since 1991. And he opened up a very, very interesting possibility, which is, I mean, really, you think about it, your sort of worst nightmare, which is the possibility, the distinct possibility in law that a private hospital, private for profit, let's say, can actually legally challenge the state aid that's been given to a public hospital. Can you imagine? Because state aid is generally frowned upon, because that's a distortion of competition. And what we have in the Republic is this kind of awful pea soup, really. We've got this public-private mix. We don't have a standalone public health system, and we've never had it. And in fact, private not-for-profit hospitals are actually a significant force in the landscape. Partly, again, thanks to the Catholic Church, a lot of them were Catholic hospitals. They built up a very, very significant power base. And they're joined at the hip with the public hospitals, and they're kind of joined in two ways. Consultants are medical consultants. We have something called a common contract, so they're all employed under this particular contract, which is really a license to print money. And in fact, 2 in every 5 of our medical specialists are legally entitled to go AWOL during working hours. I mean, if that isn't amazing, I don't know what is. Like, they can actually go, they can leave their place of work, and they can actually go off-site to look after their private patients. So can you imagine? I mean, can you imagine the kind of state broadcasting service we'd have if all of our journalists and producers and everybody else in there, makeup artists and everybody else, were actually legally entitled to leg it out of Donnybrook, during the day, 9 to 5, nip off. Oh no, sorry, actually, that's the wrong analogy. Stay there, stay put, use the facilities of the studio, use everybody's staff time, everybody, not paid for by themselves, and then pocket the proceeds. I mean, that's what the healthcare scene is actually like. And that's how bad it is. And we've just given them a new contract. I think the IMO has just actually, this is the second medical union representing consultants in the South, has just actually signed off on the new contract. So now we're paying the boys. What are we paying them? We're paying them 40 million a year, and this is just like for starters. I mean, this is one of the best deals. It has to be in industrialised countries across the world. On top of that, you get your private practice, either in-house or AWOL, whichever you're having yourself. Thanks very much. And if you take something like maternity care, we've got this, like, the net result has been, we had centralisation. That was where it happened first. I'm sort of off pitch here, and you have to stop me. So we've got this like dreadful industrialised system of care that treats women's bodies as if they were cogs in this like wheel, that's meant to actually produce babies. And we have our consultant obstetricians earning on average per head, per man, per woman, annually, $500,000 in private fees. On top of that, you've got the $250,000 in your public salary. On top of that, you've got a few extras and a few this and that, call-outs, call-ins, I mean, this is unreal. So we have so few doctors and we have such a shortage of consultants, but quite frankly, we're never going to be able to afford what we need based on the current terms. But nobody is ever going to rock that boat. And really, what the future holds, I mean, it just cannot be imagined. And also we've got the system, another kind of part of the nuts and bolts thing. You've got the common contract, obviously, so that the private hospital doesn't have to pay their wages, for example. So we've got this huge inbuilt subsidisation of the private for-profit system by the public, by us most, the taxpayers, right? And the other thing is they've got the system of joint appointments, so that our medical consultants, of whom we are so short, actually, they are appointed jointly across the private not-for-profit hospitals and the public hospital system. So everything is just designed to facilitate this like free flow, into the back pocket, ultimately. Now, since 2001, we've actually had galloping privatisation. I mean, really, really galloping. Since Charlie McCreevy brought in tax breaks, 2001, first of all, to build or refurbish private hospitals, private nursing homes, right? What happened? You had an absolute explosion in the private nursing home scene. So by like 2004, we had 400 private for-profit nursing homes all over the country, and some of them, they just look like ranches from the outside, and then you go in and then there's nobody there, except for one or two nurses' aides, and then in the middle of the night, there have been a lot of scandals in that sector, and still we haven't learned. There's absolutely no regulation, nothing, of the private sector. None. I know this is hard to believe, but that is how it is. 2002, first of all, McCreevy brought in those tax breaks. 2001 for the not-for-profits. 2002 was extended to the for-profits. What happened in 2003? Well, let me tell you what happened in 2003. HCA, which is an American chain, actually tried to come into Ireland. They hadn't even finished paying their fraud bills in the United States. We are talking actually serious money here. They actually paid the biggest fines in civil and criminal to settle civil and criminal charges under the False Claims Act in the United States. $1.7 billion. I kid you not. And what happened after that? Their successor company, Triad, was actually brought in by a Dublin surgeon, Mark Redmond, to run the oh-so-glossy and glitzy and glassy Beacon Hospital in South Dublin, that you might have heard of, because I'm sure they spent lots on PR. And Triad were actually there until very recently. They got bought out by another outfit, Community Health Systems. Community Health Systems also paid, a few bob in fraud. Personally, I don't know any American company operating in the Republic that actually hasn't got a background in fraud in the United States. They may be there, but personally, I don't know them. 2002, we brought in the National Treatment Purchase Fund. This was a mechanism that transferred money from the public to the private in a very, very effective way. What it did was it treated small numbers of patients for very, very, well, relatively simple surgical procedures, let's face it. And these were outsourced to the private sector, totally to the private sector. So you might have spare capacity in a hospital like Roscommon, which is now being closed down, but no, they couldn't do the hips or whatever it was. No, they had to go to it. So the whole intention really was to outsource clinical services, to outsource services for patients. So in a way, I mean, when you read, something like Alison Pollock's book, and you see that there was this, I mean, it mightn't be the case, but it looked like they had some kind of progression, and that they started out like with the buildings and then finished with the services for patients, where you're like right at the heart of privatisation here, where we've done it all together, in one fell swoop. I mean, we have really gone bald-headed for this, And if you want to talk about value for money, the National Treatment Purchasing Fund actually treated 17,000 inpatients for €79 million in 2006. So, we can work it out. And actually, you know what happened? We found out, the Controller and Auditor General found out that the same patients were being treated in the same hospitals. I mean, this will really amuse you, by the same doctors. And in fact, consultants were being given an incentive to actually keep their patients on a waiting list. I'm not saying any of them would do that, but the incentive was there, this perverse incentive was there. Because if you keep somebody waiting for over 3 months, then they can go and be treated privately. They can get, doctors were getting paid twice to treat the same patients, and taxpayers were also paying twice. The doctors were getting paid twice because for a start they were getting their public salary right from us, and then they were getting, in NTPF time, they were getting a private fee on top of that, and then the taxpayer was paid twice, once through the normal taxes, and then a second time an NTPF out of an NTPF kitty. So there was a double, a quadruple dysfunction, you might as well say. So that continues, and also, I mean, they discovered, that hospitals and doctors were actually charging way over the odds on the procedures. The cost of a procedure in one hospital would be tenfold in the next hospital, and this kind of crazy stuff. Because NTPF actually prefer not to have a price list. They actually prefer to negotiate secretly and to do good deals with individual hospitals. So it's been, we've had a lot of landmines exploding. We've got, particularly say in the area of cosmetic surgery. Cosmetic surgery has been wild. I mean, nobody has actually charted the boom, but it's been huge, because obviously we've come through years where money was sloshing around, for the past 15, 16 years in the Republic. One of the biggest chains called Advanced Cosmetic Surgery. It took the death of a woman who was undergoing a tummy tuck. It was in the coroner's court there 2 days ago. She should never have been accepted for surgery. They never liaised with her GP. She was extremely overweight. She would have had to lose weight before she could be safely considered. She also had other health problems, and she died under the knife. And that chain has actually been bought by a British construction firm as a going concern. So there you go. But we have racehorse owners and everybody like in the business these days, The sky is really, really the limit. But I suppose, when you consider that, one of the things that most, I suppose, exercises me is the there are so many aspects, but if you take just the US companies that have been coming in, and the fact that over the last 12 years, 4 of those companies, directly or indirectly, or by their parent, by that I mean in reference to their parent company, have actually paid a total of $2.5 billion in fraud fines to the US government over the last 12 years. And we have given them, the Irish government has given them, multi-million euro contracts in the last 2 years. And last year we actually ran a press conference to actually try and just highlight this problem. And we got a response from the HSE. We've now nationalised, by the way, we've done away with these pesky regional health boards with their pesky democratic structures and their pesky politicians, and all of that has been dispensed with. So we now have this like superstructure, the corporate model, people at the top, €1,200 a day overtime for Dr. Brendan Drum's advisors, which is more than some families have to live on for a month in the south. And so they're the ones that control everything now. There is no accountability, no democracy, nothing, and there's nowhere to go. If you have a complaint now as a patient, you've got to go right back to the medical council. There's nowhere else to go. We've obviously got into PPPs, John was talking about there, design, build, finance and operate, and particularly in cancer care. We've particularly singled out cancer care. There's a lot of money to be made in chronic disease in things like cancer. So cancer patients have been traded like commodities, like oil, gas, grain, wheat on the open market. We're building 6 oncology units at a cost of 400 million. A year later, you like this, John, that cost had leapt to 550 million, from 400, just like that, in a year. Nobody even noticed in the south, because, really, the media is quite dozy down there. Plus, of course, 72 million annually in running costs. And we've got something called a national cancer strategy, which is really a national privatisation strategy, and it's going to involve closing cancer services in like 30 hospitals. So women are just going to have to travel. There isn't a single unit that has been designated north of the Shannon. So the entire northern half of the country is actually cut off. And they brought in this, it's exactly modelled on some of the aspects, very, very close to this idea of them naming czars to actually run specific services. And that's what they've done. They brought in this guy, Tom Keane, to actually oversee the implementation of the National Cancer Strategy. But it's just a way paver, really, for privatisation, like so much else. We've got UPMC, University of Pittsburgh Medical Centre. This is like one of the biggest chains. This is the biggest employer in Pennsylvania. And they tell us, like, this is an academic institution. I'm sorry, don't even have anything except the remotest connection with the University of Pittsburgh today. Give me a break. So at the conference today we had Michael Cullen telling us, about this like academic institution, UPMC. UPMC, another company done for fraud under the False Claims Act. And generally what it is, it's insurance fraud. It can involve patient abuse. There's a lot of physician bribery out there. And those are the main charges, actually. Those are the recurring charges under the False Claims Act. Insurance fraud, up to their eyeballs in Medicare fraud. You are talking billions here. You are just talking Enron League fraud. Not in the case of UPMC, they have just been done for like nothing, just like 20 million, It just doesn't even feature on the screen here. So they're providing radiotherapy to our cancer patients on 2 sites. They're also tipped to be providing radiotherapy in Letterkenny, Donegal, because women in Donegal are becoming a nation of one-breasted women because they have not been able to access radiotherapy. And the state has now apparently committed itself. There is going to be no more radiotherapy in the public sector in the Republic, believe it or not, in what was, until very, very recently, one of the richest countries in the world. It is an obscenity, really. UPMC are also running 3 co-located hospitals. We've also gone for this particularly invidious model of privatisation. These co-located hospitals are just, we're building private hospitals on public hospital grounds with tax offsets up to half the cost of the build. Developers are just like laughing all the way to the bank with these tax offsets. But these hospitals are going to be right in there, in the heart of the public system. It's like turn right for the public, left for the private, even a common entrance. They're going to be poaching our hospital consultants. Now, some of them would only be too happy, right, to treat their private patients in the co-located hospital wing. But it's cherry picking, as John mentioned, cream skimming wealthy patients. The only thing I suppose they won't be doing is actually patient dumping, which you might have seen in Michael Moore's Sickle, where they literally dump them on the sidewalk sometimes if they can't afford to pay. And they're going to be sharing all sorts of things. Apparently they've got the service level agreement, which is going to involve everything from food to linen to laboratory, getting into really heavy stuff here, also very profitable stuff, and other diagnostics. So the agreement is there between the public and the private. If the private shares something, they can go to the public and get it as of right. But interestingly enough, on this business of A&E, which I think, John, you mentioned, they're committed apparently, and this is actually going to be very dangerous, to doing 24-hour A&E. And they're committed contractually to caring for all private patients, even the ones who come in through the doors of A&E, because in the South, 71% of all admissions actually come in as emergencies, because that's how bad it's got, because we've had decades of underfunding and a total hospital economy based on scarcity, planned scarcity. So if you add the whole thing to the mix, you add all those other private hospitals out there that are mushrooming up with these glorious tax breaks, and you add it all together to the pea soup, 13 tax-fueled investor-owned hospitals, plus the colos, of which apparently there will be 10. At the moment there are only 6. And you add in even the lowest margin possible for the for-profit beds in our public hospitals, we are going to end up with a situation where 45% of all our hospital beds will actually be private for-profit beds, which is going to make it one of the highest in countries with modern healthcare systems. So that's really how bad it is. Getting back to women there briefly, diagnostics. What did we do last year? We outsourced to clear a backlog, which was of course induced by underfunding anyway, of women's smear tests to Quest. Now Quest is one of those companies again with a very long track record in fraud in the United States. 1996 to 2004, paid almost $300 million in fraud fines, right? Everything from overcharging for cancer blood tests, I mean that's how bad it gets, to insurance fraud, which is a very, very reliable, good old insurance fraud. Here we go. Quest has just got the national contract for women's smear tests for the next 2 years. Last week, I actually decided to seriously investigate this and discovered that UPMC, my friends, they obviously have a chain of hospitals in Pennsylvania. One of those is McGee Women's Hospital in Pittsburgh. They've had scandal after scandal there in the laboratory end of the business, and I discovered that it's actually a common practice to put the electronic signature of a doctor on the smear test result. That doctor will have never seen the slide. And you know, so we've gone from a situation where we had our own laboratory people who were medical scientists with degrees, a lot of them postgraduate degrees, so they're anything 3 to 5 years of university education, over to the States where it seems that those technicians, and I believe it's also true, but John could correct me, in Britain, here in the north and on the mainland, that to technicians who may have had as little as 3 months training in reading those slides, and it's only if they see a problem that they refer it on to a pathologist. Apparently Quest allegedly got the contract because they were 3 times cheaper. But I mean, the question I've raised publicly is, I mean, does that mean the quality is going to be 3 times worse as well? So that's something we have to think about. But in fact, in 2 years' time, when that contract comes up for renewal, the public hospitals aren't even going to be able to compete, and that is because all of those people will have lost their jobs, or a lot of them, and they will have emigrated. I mean, we expect, so we're farming out the smear test, but we're also going to be exporting the highly skilled personnel staffing the labs. You really want to finish up. You know, there's a revolving door there between the public and the private, and it's been documented in Britain. Well, you know, we have it too. We're privatising our public administration. And you know, the latest round that we're looking at now, just to finish up, we have in the Republic 52% of people hold private health insurance. So I mean, obviously there's a huge problem there in terms of funding. You can't control anything. You've got all of these competing insurers, and we always had a few tiny insurers around the place. They were sort of not-for-profit things. Then we had VHI, a semi-state body, which they're now in the process of privatising. Bupa came in for a while, left again. I won't go into that particular row. We've got Vivus now, and we've got Quinn. We're about to close. We've got 53 acute public hospitals. We're about to close up to 40 of those across the next 6 years. So there is going to be murder. We're closing 40% of all of our acute hospital beds, all of our urgent care beds, up to 5,000 beds are going. So we're just stripping it out systematically under various banners: the banner of the National Cancer Strategy, the banner of regionalisation or centralisation, all of this rhetoric around centres of excellence, which of course we saw in Britain as well. And this is going to leave vast gaping wounds in the public health system, and those private for-profit corporations are just going to rush in there and fill those gaps. There you go.